Welcome to the 10th webinar of the PCOs Society of India, which is being held in collaboration with the Monash University. And this we have been doing once every month, and this is our 10th webinar to date. We all know that with PCOS and pregnancy, there are quite a few complications or issues which are related to it. And we all know that there's an increased risk of miscarriages, increased risk of glucose intolerance, diabetes mellitus, congenital malformations, neonatal complications. All this increases almost 2 to 4 times in pregnancy and at delivery. Now, this all, of course, depends on various variables, such as age, BMI, and also ethnicities. And for us, especially being in India, where we are the second largest country in the world with diabetic population, we need to be more careful and we need to be more concerned about diabetes mellitus or gestational diabetes in our PCO patients. As a matter of fact, we do see quite a few PCO patients during our practices. International guidelines have been developed very recently, the latest ones which have been published in 2018, and they have been published by 4 major organizations together. That is the CRE-PCOS, Monash University, and led also by ASRM and ESHRE. Along with them, there have been other 30 to 35 organizations which have collaborated with them, and PCOS Society of India has been one of the few organizations which have been invited to be part of these webinars. And this is our endeavor to bring the webinars to you, to bring all the guidelines to you in a very nice clinical format, where one of the authors of the people who were involved in the development of the guidelines is with us. And today we have Professor Rog Hart, who has come to speak to us, and Professor Hart will be speaking to us on what should we expect during pregnancy in PCOS. Are there any precautions we need to take before, after, and during pregnancy? So we will welcome Professor Hart to our forum, and I'm very happy to introduce you, Roger. And Roger is a subspecialist in reproductive endocrinology and infertility, being the medical director of fertility specialist of Western Australia and professor of reproductive medicine, deputy head of the division of obstetrics and gynecology at University of Western Australia. He has active research interests in the early life origins of male and female reproductive disorders, polycystic ovary syndrome, and all aspects of infertility management. We will request Professor Roger to give us a 25 to 30-minute talk, followed by a 1-hour interaction with all of us. Please, I request all the global audience to post your questions on the window which is on your screen. You post your questions, the questions will reach me, and on your behalf, I will ask the questions to Professor Roger. So, Roger, can I request you to start with your talk?
Thank you very much, Dr. Shah. I'm very grateful for that introduction, and congratulations on running these successful webinars. So I'm very grateful for the invitation, and I'm very pleased to share this with your audience. So thank you very much for your gracious invitation. So what I want to do is to share my talk with you today, if I can get that up on the screen. So here we go. So basically what I've been invited to talk to you about is what we should expect during pregnancy with PCOS and any precautions we should take. And that's my remit over the next 20 minutes. So I think the main thing, and this goes for all women, couples trying to get pregnant, is the preconception care is crucial. And I believe particularly in India, this is a real issue, is to focus on the preconception care, particularly related to diabetic risk. So as Dr. Shah kindly says, these guidelines come from the recommendations from the International Evidence-Based Guideline for Assessment and Management of PCOS. And so basically it's essential to try to address the woman's health And ideally, the male health to try and get as healthy as possible, because the time of conception is crucial from a male and female point of view. But particularly focusing on the woman here. So she needs to be well on a folic acid replacement. And it's particularly, as Dr. Shah has said, the Indian population has a propensity to diabetic risk. And it's crucial that we try to mitigate against that by being fit for pregnancy. So ideally, with an ideal BMI for women in India is under BMI of under 23. And so the guidelines would recommend a structured weight loss program to try to achieve that. Because women with PCOS have particular predisposition to diabetes in pregnancy, hypertensive risk, and also, unfortunately, mental health issues related to their disorder and potentially body image. So it's intentional also to address preconception care by performing a glucose tolerance test, lipids, and triglyceride measurements in a woman with PCOS. So PCOS, what is it? I mean, we all have an idea. You're all obstetricians and gynecologists, but I think we should really think of PCOS as a metabolic condition, but with reproductive consequences. It's part of a whole body condition, and we're just looking at the small window of reproduction. We're all aware, as Dr. Shah has alluded to, of the risks in pregnancy related to miscarriage, pregnancy-induced hypertension, preeclampsia, gestational diabetes, a risk of premature delivery, growth restriction, but also smaller babies, but also a proven higher macrosomic risk. And unfortunately, that tragedy of stillbirth. And as Dr. Shah said, there appears that the child is at greater risk of congenital malformations and risks in early life. So what we're going to also talk about is potential mechanisms and how we can potentially mitigate those risks. So you'll all be aware there's been several meta-analyses performed by Tsoulis in 2009, Quinn 2013, Kajurov in 2011. But the most recent meta-analysis of the adverse pregnancy outcomes was in 2016. And this, by Hai Feng et al., basically looked at 40 studies, 15 of which were prospective, looking at 17,500 women with documented PCOS, comparing them to 125,000 women who didn't have PCOS. And what were the outcomes? Generally, the populations were relatively young and lean, perhaps more Asian population more than the Western population who tend to be more overweight. But what did they find? Well, as Dr. Shah has said, gestational diabetes, 3 times as common. Preeclampsia, 3 times as common. Alerts. Okay. Yeah. So basically, the most recent meta-analysis by et al. Is a meta-analysis of 40 studies, 17,500 women or 124,000. As Dr. Shah has said before, that the gestational diabetes is common, 3 times as common, preeclampsia 3 times as common, premature delivery 1.5 times as common. What is the effect for the baby? They didn't appear to find too much of an effect for the baby. They didn't find, interestingly, an increase of small for gestational age or for large for gestational age. The main thing that they found was a higher risk of neonatal hypoglycemia, as you would expect. But perinatal death was twice as common. They didn't find a higher rate of congenital malformations. So therefore, from what Dr. Shah has said at the start, and what I've alluded to already, why is this? Well, perhaps the risk is not the same for all women with PCOS. I mean, it's an interesting study from Iran, which looked at, we all know PCOS is associated with cardiometabolic disorder. What they did was they looked at the risk according to the age of the woman, and they found that as the woman get older, their risk of hypertension and metabolic syndrome tends to equate more to the general population. So it appears that a woman with PCOS is at a greater risk than her peers at a younger age, but as she ages, she equates more to the background risk. So it's diluted with age, so it therefore would affect the age of the population you study. It also appears that hyperandrogenism is at the root of all this, and we'll get to that shortly. So, what are the potential mechanisms of causing the adverse outcome with PCOS? Well, as you'd expect, it probably relates to placenta. The placenta, as you know, relies on trophoblastic infiltration of spiral arteries, facilitating a low resistance perfusion for the fetus. Now, Stefano Palumbo et al. Has studied this at great lengths over a decade. Basically, 2006, he studied non-pregnant women and found the uterine artery resistance was greater and less of endometrial blood flow in women with PCOS. And then he studied them later when they were pregnant, and he found that they have an increase in the uterine artery Doppler indices. So therefore, there seems to be a perfusion problem to the uterus and also the endometrium. What do the placentas look like? The placentas of these women have got a higher rate of vascular lesions. There's infiltration with intervalitis, spiral artery changes. And it appears that it was greater in the women with higher androgens and insulin resistance. And then with a collaboration with including Bart Foser in 2015, basically in a review in Human Reproduction, they said PCOS is a state of inflammation and with higher CRP, ferritin, white blood count. And in pregnancy, it's therefore hardly surprising the risk of miscarriage can be up to 8 times greater. Dr. Shah, are you getting, you seeing the screen okay now? Just keep.
Yeah.
Fantastic. Good. Okay. So let's explore that more. Is it the phenotype of the PCOS? As we all know, there are women that can be the hyperandrogenic form, and the women can have the central obesity form, the women with the irregular or absent menstrual cycles. Are they all the same? We all know that there's potential postulated theories of why women may get PCOS. Is it genetic, potentially epigenetic influences? We do know there's very good evidence from animal models that a high androgen environment may predispose to PCOS in the offspring. Perhaps it's due to endocrine disrupting chemicals. Potentially, it's the protective methods of placental aromatization and the sex hormone binding aroma that may protect the fetus that's impaired in these women. Potentially, as we believe that postnatally, the influence of obesity may express the phenotype of PCOS. But increasingly, we're looking at this, what's called a two-hit hypothesis. There's the antenatal predisposition to PCOS exacerbated by the postnatal, potentially obesity risk, amplifying the woman's risk of the phenotype of PCOS. So when we talk about PCOS, we are talking about a diverse group of women. As I've alluded to, there's good evidence from animal models that if you expose a female fetus to super physiological levels of androgens, you program a form of PCOS in the offspring. And so Peterman et al. In 2002 showed that women with PCOS have higher androgens in their blood. Potentially, if you could imagine there's a fetal sex hormone binding globulin deficiency or placental aromatase deficiency, they're exposing the fetus to a much greater risk of high androgens, programming PCOS. It's potentially this fetal hyperandrogenism and hyperglycemia may influence the bioavailability of amino acids, influencing growth factors, consequently organ development and fetal growth. So potentially that's how the hyperandrogenism is causing a problem for the fetus. And some amazing work this year by Christ et al. This was published this year. They had phenotyped women at an infertility clinic before conception. So these were PCOS women in an infertility clinic, and they compared them to the Dutch registry. The Dutch are very good at this with these national databases. And the primary outcomes were looking at the risk of preeclampsia and premature delivery. And as Dr. Shah has alluded to, as you wouldn't be surprised, at twice the risk of preeclampsia and premature delivery in this population. There's the figures there. But what was the cause of that? So they did some regression analysis, and they found that preeclampsia was greater in those women who had a higher pre-pregnancy free androgen index. Prematurity was related to the higher fasting blood sugar, preconception. As you know, hyperinsulinemia is amplified in pregnancy, so that will almost certainly be worse in pregnancy. Prematurity related to hyperandrogenism preconception, 1.5 times. So 50% greater risk of prematurity related to preconception hyperandrogenemia. And any adverse pregnancy outcome was related to higher insulin and higher testosterone. So that's some great insight into potentially the mechanism of this. And this is further work by Helena Teed's group at Monash University. So Dr. Kamani, and what she did was she looked, is it obesity really that's the root of all this? Is it obesity that's the problem? So basically she looked at the pregnancy complications to see whether it was related to obesity or whether it was independent of obesity. And so basically what she found was that we're doing a process of meta-analysis and an analysis called meta-regression. As you might expect, women with PCOS had a greater BMI than at preconception than women without PCOS. We know that. But what was interesting, women with PCOS, they had a greater gestational weight gain by about 1/4 kilo than women without PCOS. All pregnancy risks were increased. And then they looked at their analysis to see whether obesity was related to it. And sure, as we've already alluded to, every pregnancy complication you can think of was increased. But it was independent of obesity. Independent of obesity. So it's not obesity causing this. However, when the women got very big, so BMI greater than 30, because obesity is such a big problem in the big women, the risks were similar. But the women with a BMI less than 30, it wasn't related to obesity. It was the intrinsic PCOS phenotype that led this. And it mainly related to hyperandrogenemia because the risks were not increased in those women who weren't hyperandrogenic. It appears that hyperandrogenism is what's related to it. Also, the greater risk was also related to if they've undergone IVF treatment. And there's also a geographic variability. But interestingly, mainly in the Western countries, that was a greater risk. In summary, really the outcomes were worse in the women who were hyperandrogenic. And what about the effect on the fetus? So they looked at the fetal outcomes. So what's the impact on the fetus? Same analysis and meta-analysis and meta-regression. As again we've said, obviously there was different studies because not all studies looked at the fetus. They found the gestational weight gain in the PCOS women in this were almost 1/2 kilo greater than in women without PCOS. The rate of growth restriction was similar. Preterm birth was increased 60%. And basically they found the highest rate, Australia and New Zealand was the highest risk, but they found that the greatest risk was also in women who didn't ovulate and were hyperandrogenic. Again, the greatest risk for the fetus relates to hyperandrogenemia. We're finding a common theme here. Birth weight. We've always said that these babies are bigger, but interestingly, they're lighter, 11 grams lighter. But what you do have is a population of the really big babies, perhaps the ones with a diabetic control support, is greater. So the tendency is for the babies to be smaller, but there's a subset of them that are actually larger. And again, the greatest risk in the hyperandrogenic women who had undergone fertility treatment. And so this Helena Teed's group sort of looked into this. Why is this? And they believe that women with PCOS, we know that they have abnormal appetite regulation. And their energy expenditure is different. Different psychological functioning. They have higher energy intakes. So that may be underlying why they're at greater risk of the problems. So therefore, metformin, which we sort of dish out regularly, should we let these women continue it on into pregnancy? Well, this is a meta-analysis by Feng et al. Quite recently, and it showed that it does appear to be a benefit, but it's related not to gestational diabetes, which you'd all expect. It's related to miscarriage and premature delivery. This group, it didn't show any evidence on preeclampsia or gestational diabetes, but most studies tend to stop the metformin early in pregnancy. So there's not many studies where they continue it on. So this is what they basically showed, and there's the odds ratios, and you can see no difference here in gestational diabetes. If you get to the side of the sum chart diamond beyond to one side of unity, that shows a statistical effect. no effect on gestational diabetes, no effect on preeclampsia, but a significant reduction, basically a halving of the rate of miscarriage in women who take metformin, and a halving of risk of preterm birth. And this can be even women that do not take it through pregnancy. On the back of this, a study was published in The Lancet early this year. This is an amazing study. It's called the PregMet2 study. So it's a double-blind, multi-center study performed in Scandinavia. And built on previous pilot data, they thought that it appeared that metformin reduced late miscarriage and preterm delivery. So what they did, they used that as the primary outcome. They used the Rotterdam criteria to define PCOS. They gave metformin twice a day, 1,000 milligrams in the first trimester, twice daily. Folate normal dosing we recommend. These women had a normal glucose tolerance in pregnancy. They basically aimed to recruit 1,000 women, but as often in this situation, only got half that, 500 women. They found that almost 2/3 of the women adhered to the medications. We know a major problem is the nausea and bowel-related side effects of women taking PCOS. What they found on intention to treat analysis is a halving the rate of late miscarriage and preterm birth. Gestational weight gain was 2.3 kilos less. Huge amount. Now, because the study was underpowered for these outcomes, they pooled the data with their previous pilot data, which had been followed the same protocol. We can argue the toss about the statistics in that, but basically they ended up with 800 women, and they found the rate of late miscarriage or preterm birth was 5% compared to 10% in the women that didn't take metformin. Highly significant. And again, who was it applicable to? They did a subgroup analysis. It was the women who were hyperandrogenic, the women that were significantly overweight, BMI greater than 30, the women that had used IVF. Fascinating. So what is the mechanism? What the heck is causing this? Because we would expect the mechanism relates to gestational diabetes. We've shown it doesn't. Interestingly, metformin seems to act down a pathway, don't ask me how it works, the mTORC1 pathway, which is a key signaling of onset of labor. And metformin is a significant inhibitor of this. Potentially, that is a mechanism. One point of concern is there was noted to be larger head circumference in the children born from metformin. This is something that we should be very cognizant of. We all look for hard outcomes like birth weight, but it's the longer term outcomes that are important. This begs the question, is metformin safe? Metformin freely crosses the placenta, and people have looked at the cord blood of babies born exposed to metformin, and the fetal levels of metformin are greater than the mother. And most of the studies on safety relate to women that use metformin to conceive and did not take it for long into pregnancy. For instance, the 9 studies that are out there, only 3 continued into pregnancy. And many of them are for women who use it for type 2 diabetes. So that's not really applicable in this situation. But they didn't show a hard outcome of a higher number of malformations. But remember, a congenital malformation is a really gross outcome. What are the more subtle things risk as we go through childhood? So what are the longer term risks? Well, people have looked at 10 studies of children who've been exposed to it through pregnancy, and that's gestational diabetes and also women with PCOS. And there's only 10 studies, only managed to have 778 children up to 7 years. But these children were a greater weight in childhood than those that weren't exposed to metformin. However, the comparison group was women who took insulin in pregnancy. So it's really, I don't think we can relate this to our PCOS cohort with normal glucose status. But I think before we can really go out there and recommend everybody takes it in pregnancy, we need to have the longer term outcome studies. So in conclusion, Dr. Shah, I'd like to really say that PCOS pregnancy risks are all the risks you've alluded to in your preamble. But perhaps it's more related to women with a hyperandrogenic phenotype. There may be regional differences, particularly it appears in Western countries. relating also to use of IVF, and much greater in the women who have BMI over 30. Metformin does appear to have a benefit related to reducing risk of late miscarriage and premature delivery. More follow-up studies are required for the children born from metformin exposure. So I think one, as well as that, the overriding sentiment I want to give you is right, I said at the start, how it's so important to get healthy, fit, keep the weight down to conceive, because pregnancy should be viewed as a window to future health. A woman that gets gestational diabetes in pregnancy, a massive increased risk of diabetes later in life. She gets hypertension in pregnancy. It's a window to the future. She's on a pathway to cardiovascular disease. So get healthy before conception. Look at your patients carefully in pregnancy. Follow them up after pregnancy, because many of them will remain diabetic, and many of them will have a risk of hypertension developing. So screen them postnatally, offer that long-term advice and caution. So that's how I'd like to end. Thank you very much, Dr. Shah.
Professor, I think you've done a brilliant job, and the talk has highlighted exactly what we wanted to hear. And now we would like to do a little practical discussions on what really, how would you say, for example, you have an infertile patient, you run an IVF center, and you have a patient who's come to you who's 37, 38 years old. She's advanced reproductive age, and you want her to lose her weight before you start therapy because you're concerned about her complications which she's likely to develop during pregnancy. So what do you do in such a case? Do you wait for an ideal weight, or you go ahead and just counsel her about the problem she's likely to face?
Yes, and that's a great question. Obviously somebody's trying to sort of demolish your ceiling, I think. That is it's such a difficult, and it applies to not just PCOS, it's tubal disease, male factor infertility, and it is so difficult. As we know, fertility rapidly declines from 37, 38 onwards. But I think evidence would suggest, mainly from Rob Norman's work in Adelaide and similar people doing similar studies, that even just a concerted effort for a short period of time to lose 5 to 7 kilos will substantially improve the reproductive outcome. So basically, I do not believe deferring treatment for 6 months when you're 37, 38 is harmful. I think it's optimal opportunity to do that. Get her blood sugars checked, get her on her multivitamins, get her on a structured weight loss program, and the gain, most psychological gain, is say, we will do this in 6 months' time. I will see you several times. We'll get you on this program, and you'll do so much better. Because when things don't go well in life, we like to reflect and think, I tried my hardest. I've got that emotional gain. I tried. There's nothing worse than entering into it and it's not going well, but you didn't engage in the process. 6 months, hard work, and then do it. Evidence suggests that's the best thing to do.
Yeah. So I think I totally agree with you. We make them lose at least 5 to 7 kilos and try and get them, pregnant as fast as possible as soon as they've been able to, which is easily achievable. Between 3 months, I think they can definitely get rid of 6 to 7 kilos. The next question is that you mentioned that it's the weight gain during pregnancy which is really the one which causes the problem. So what kind of a diet do you put them on so that you can restrict their weight gain to maybe 5?
I mean, this is very difficult. Obviously, I love Indian food, and you have many diverse regional diets and food. So basically, the guidelines would suggest it should aim at calorie restriction, a low GI diet, achievable targets, not setting unrealistic targets, in association with exercise, and it's not killing yourself in the gym. It's not going running when you've never run in your life before. It is regular exercise. So that may be walking at the gym. I'm fortunate to live in a beautiful place, as you can see the light out there. So going outside for long walks, but I know if you're living in a very busy city, it's not feasible. But treadmill, 45 minutes, put the earphones on, it's going for brisk walking, it's not sprinting. Hardly any of us can do that, but it needs to be daily. Increasing the metabolic rate associated with reduction in calorie intake. So a low GI diet, calorie reduced, with a balanced diet, taking the multivitamins, because evidence would today suggest that those women that have rapid weight loss, particularly those women that undergo aggressive things such as gastric band surgery, that is actually very detrimental for the fetus. Women who lose a lot of weight, who undergo gastric band surgery, they must not get pregnant for the first year. The risk to the baby is substantial. That rapid weight loss is not good. As you say, 5 to 7 kilos, achievable goals, 3 to 6 months, the best way to proceed. Yeah.
But sometimes our pregnant women are a bit concerned when we tell them we don't want you to put on too much weight. They're concerned their babies will get growth restricted, will not grow well. So as a matter of fact, we recommend to them to have a high protein diet and improve the protein content, cut down on carbs and stop the sweets, and which we are very fond of eating. And
I know. Every Indian patient I say, how much sugar do you put in your tea? Only Indian patients put sugar in their tea.
And even the oil they use in the food, we use in the food, it's quite hair. I mean, a lot of fat in the diet. So we try and restrict. The biggest concern comes from their mothers and mothers-in-law who say, oh, how will my baby grow? That's the concern they have. And then sometimes you do have growth-restricted babies in PCO patients, and then they would blame our diet for that particular reason. So we have an issue on how to make them eat a right diet so that they don't. Of course, exercise is something we will strongly recommend.
Good.
So we go to the next question, is that you said that when women have hyperandrogenemia, they are the ones with more problems and more complications. So even insulin resistance is one of the causes of the issues. So how do you control? We do control it pre-pregnancy. We bring down their androgen levels. We try and put them on metformin. But once they get pregnant, then what do you do?
Yeah, and that's fantastic. So because they're inherently prone to it, how do we control hyperandrogenism? It's a great question. Because the best way, as we know, is the contraceptive pill. I mean, that's the best way of controlling it. But the Cochrane review would suggest that metformin is just as effective at controlling the hyperandrogenic symptoms of a woman with PCOS. Yeah, it's sometimes not as pleasant to take, because many women, as you'll be aware, suffer terrible side effects from metformin. Some women take it and say, I don't know what fuss is, doctor, but some are really disabled by terrible distension, gastric symptoms, really, really unpleasant. So I encourage them to start it slowly, gradually increasing the dose over a series of weeks to try and get that tolerance. And yeah, I agree. I think you've got to take it into pregnancy, but I think certainly I would say up to the first trimester, but I don't think the evidence yet is really there for the longer term, because as Dr. Palumbo's data is suggesting, it's all about the placenta. So basically, if you're treating the hyperandrogenemia preconception and early pregnancy, I believe that gets at the heart of the problem due to that placental inflammation, poor spiral artery invasion. So I believe that is where the benefit arises from. So great question. Certainly we do not want women taking anti-androgens in pregnancy. I mean, you're already struggling with the mother-in-laws already, but if you make them take anti-androgens in pregnancy, I think you'll be even more trouble. So don't do that.
Yeah. So pre-pregnancy, we control it with oral contraceptive pills, with whatever we can. But once they are pregnant, obviously we can't use products like that. So yes, but we can give them metformin. But then the concerns have always been, is it okay to use metformin in the first trimester? Is it okay to continue through the pregnancy? We know that the risk of GDM and PIH probably would be less with the use of metformin.
Well, I mean, that's interesting. It does. There's many, many studies, and none of them show an effect on gestational diabetes, which is staggering. It seems to definitely reduce preeclampsia. I'm sorry, definitely reduce premature delivery, possibly preeclampsia, but not gestational diabetes. So what is going on? Well, so preeclampsia is perhaps related to early placental development, which you've been talking about. Premature delivery is related to inflammation, again, an early pregnancy potential problem. So I do think taking it the first trimester, I think, is reasonable. I don't think the evidence yet is there for longer term. So I do not think that there's any harm in taking it for the first trimester, which is a crucial time for the placenta. You're treating the hyperandrogenemia, you're treating the inflammation. I think that's the reasonable thing to do.
Yeah. So you do use metformin in the first 3 months of pregnancy, and in case your patient cannot take the metformin for all the side effects which you mentioned, do you ever use inositols in those cases?
No. I don't think the evidence is really there to support that. So I don't. I just if you're able to take half the dose, that's fine. I always describe it as metformin is a bit like taking an iron tablet if you're anemic. It helps. The more you take it, the more the merrier. It's not like an antibiotic where you must take what I give you, otherwise there's no point doing it. That's the way I explain it to patients.
Right. But do you use inositols at all in your country?
No, I don't think there's any firm evidence there for it yet.
Okay. There is no evidence, I agree, but in a situation where it's like an adjuvant, sometimes we do use products which there's no evidence on, and we study. The question is, I was wanting to know, what do you all do in your country?
I don't. I make them persist with a little bit. That's what I do. Whether that's right or not, there's a great study to do it. Fantastic. Yeah.
The other question we have is that there are certain investigations which we do for all our patients as pre-pregnancy to know whether everything's okay. Then during first trimester, second trimester, is there anything different to do for your PCO patients?
Yeah. So we all know this rarely happens, but I was just lecturing some GPs yesterday. I strongly encourage all women, ideally and men as well, the couple to go to see their general practitioner before conception and say, I'm here, doctor, I'm planning a family, what should I do? I mean, it sounds stupid. You're saying, like, I don't really know what to do. It's pretty basic. We learn that at school. But it's not. It's because a lot of patients, forget PCOS, have got an underlying medical condition. Many patients are taking medication for all sorts of things: thyroid disorder, mental health disorder, antidepressants. So it's essential that they see the doctor beforehand. And that's the doctor. Hopefully, it's a gynecologist with your expertise, but he's talking about getting fit for pregnancy, taking your folic acid. And a woman with PCOS, the guidelines suggest she should have a glucose tolerance test before she embarks on pregnancy, because a significant number will have unrecognized and impaired glucostasis. And there's no two ways about it. Having a high fasting glucose in the first trimester is a major risk of congenital malformations. So that's a crucial thing to do. So it's fantastic if your patients do come along to see you before they get pregnant. But as you know, many don't. Many only come along when they've not got pregnant. But ideally, they should be encouraged. So if you're seeing women early in their lives and with PCOS, say, when you're going to start a family, come along and see me when you're planning to do that. Just get married and then come along and see me. And I can tell you, let's get you healthy for pregnancy. Because as you know, when a woman is pregnant, the die is cast. And that's the trajectory of health for that child. So it's crucial that the male health and the female health are optimized for that point of conception.
What percentage of women in Australia come for a preconceptional counseling before getting pregnant?
I think I would be disappointed with that result. I think it's a very low level. I'm like a stuck record. I tell my medical students with teaching, when you're seeing your patients for a pap smear, on the pap smear program, you get that relationship over several years. When you're ready to start a family, come along and see me. Yeah. I think the preconception care is crucial. I mean, we even know, there's evidence to show now that the man's blood sugar at the point of conception affects the metabolic trajectory. We're focused on the women and that getting them fit for pregnancy and the blood sugars in pregnancy. It's the man. It's seminal plasma microRNAs are controlling the expression of metabolic risk. So talking to the woman and telling her off because she's overweight, look at the man as well. Is he fit to get her pregnant? He needs to address it. So it's not a purely female thing. I'm very strong. It's both of them have a responsibility.
Okay. So every couple who will come to you pre-conception, you would evaluate the male partner with
Absolutely.
a semi-plasma microRNA?
No. It's the same. I wouldn't go to great investigations for the woman either. I would just look at him and say, do you think you're fit? Are you a fit individual? Are you proud of your health? If you think you can do some more, well, do that, because we're talking about the health of your child. So certainly he should gain to lose weight. He needs to stop drinking, minimal alcohol intake. He needs to take a multivitamin. So optimize the time. So I'm a very strong believer in male health at the time of conception.
Yeah. I think we can also probably talk to them about the transgenerational continuity of PCOS in their progeny.
Correct. Yeah, exactly. Yeah. So absolutely. So as I've sort of alluded to in my talk, again, it's unfortunately picking on those poor women that are hyperandrogenic. As we sort of say, that it appears that the hyperandrogenemia programs PCOS in the next generation. And so absolutely. So transgenerational conditions. I mean, that is the fascinating sort of new window. Epigenetics. Yeah.
So in Australia, as you guys have done so much of research in PCOS, is there any program which the government offers for preconceptional care? Any kind of awareness programs or something like that which will make women come in for a consult much before getting pregnant?
No. There is no Medicare funding for preconception care. But any interaction with a healthcare a doctor or a specialist does have a Medicare component, and so the woman seeing the doctor would have reimbursement for that. So yes, so there is. So it's not an active program, but there is some reimbursement for that.
Okay. And if a woman is pregnant and she's completed her first trimester, and you do the fasting and the post-glucose sugar, you have done it before she gets pregnant. She comes back pregnant to you 6 months later. Then would you like to repeat it, and how often do you repeat the sugar?
Yeah, great question. Well, it's a guideline in Australia to do a blood glucose screen on all women with GTT, glucose tolerance test, at 16 to 18 weeks of gestation. So that's a standard, and so that is routinely performed. Obviously, a woman you're really worried about, you would probably do that sooner. As I said, abnormal blood sugars in the first trimester is a significant risk of congenital malformations.
Yes. And what about the late trimester? Do you tend to repeat the sugars again for gestational diabetes?
If the woman's at risk, we do that 34 weeks. Yeah.
34 weeks you would repeat it again?
Yeah.
Or
32. If it's fine, then we would. If she's got a risk factor, overweight, PCOS, yes.
Mm-hmm. So in short, for gestational diabetes, you would repeat the sugars again in the third trimester to confirm whether...
No. Screening for it, yes, but if she has gestational diabetes, obviously that needs to be managed. So no, we don't just say we've diagnosed it and send her on her way. No. So then she would see the diabetic educator to look at her diet, potentially whether that's beneficial to take oral medication, whether she needs to go on insulin. So that's a diabetic educator and her obstetrician would manage her diabetes. That's different. I'm talking about women that have a normal GTT in early pregnancy, but we think are at risk. We would repeat it later to see if she's developed it late in pregnancy. Because that is when the macrosomia is a risk. Yeah.
Yeah, but when she doesn't have any impaired glucose readings earlier in the pregnancy, you would want to repeat it once more in the third trimester, looking for ICP. Yeah.
Yes, absolutely. Yeah.
That's exactly what I wanted to bring in. And what about the hypertension? Do you do any tests to look for pregnancy-induced hypertension?
Yes. So basically, any interaction with a either midwife or doctor, whether it's a GP or a specialist, it involves screening for hypertension. As you're aware, women tend to have a fall in blood pressure in the first trimester, so it could be unrecognized that she could have been hypertensive before conception, and it's not recognized because it drops in the first trimester. So it's important that it's repeated on regular instances through pregnancy. And certainly a woman that's hypertensive in the first trimester is a major risk for an adverse pregnancy outcome. Yeah.
Mm-hmm. And you've got a patient, say, who's had, sort of gestational diabetes during pregnancy, post-delivery. Her sugars come normal, her blood pressure settles down. What is the advice you give her post-delivery? 6 weeks delivery, yeah. She's come back to normal. What do you tell her? How often does she need to come look for diabetes, look for hypertension?
Yeah, I think if it's completely normal by 6 weeks, I think that's fine. It's probably just maybe at 6 months and a year, but she certainly needs her GP, family physician, or if you're seeing her for other gynecological reasons, you need to do on an annual basis. I think I really think pregnancy is a stressor of the body, and obviously it's physiological and it's a marvelous thing. But for some ladies, it releases some potential window into future risk later in life. So a woman that does get these concerns of preeclampsia, pregnancy-induced hypertension, or gestational diabetes, that is a red flag that we need to be alert to this. So they need to be, the minimum is, please go and see a doctor every year because you could be at risk of this. And as we all know with these conditions, early intervention and treatment gives long-term benefits. So very wise, Dr. Shah.
Yeah. So this is what we would recommend, because this PCOS tends to go ahead in different phases of life and we see it in different ways. And I think we need to look at every opportunity where we can guide our patients that you need to, look for this as you go further, or further when you're 40 plus, probably you need to look for if you've got menstrual dysfunction, you've got some abnormal uterine bleeding, you need to at least look and see whether endometrium is developing well or it's developing to hyperplasia. We do find quite a few polyps occurring such women in the 45 age group. So in short, we are looking at all sorts of issues which can come up with women. Do you find any special thing happening to these women when they get menopausal? Or you don't see them at all?
I tend not to these days. As you're aware, there are very increased risk of endometrial hyperplasia. These polyps you're alluding to, a risk of endometrial hyperplasia and malignancy. So I say to patients with PCOS, and I say to patients with endometriosis, this is a chronic condition. It's like asthma. It's something that's like a bad back. You have got a risk of this for life. It's not a serious thing. We just need to manage it. So we need to be sensible. We need to embrace a healthy lifestyle. We need to manage the various epochs in life, controlling the hyperandrogenism by the pill, then a phase of life where we're trying to have a baby, minimizing our risks in pregnancy, and then family spacing between the children, and then protecting ourselves for the future risk of you've alluded to with your endometrial hyperplasia. So something like the Mirena IUCD, that is a fantastic.
That works brilliant.
Yeah, absolutely.
That works brilliant
for these women, because it gives them their menstrual treatment. It really controls their periods. It protects their endometrium from this significant risk, because particularly the overweight women with PCOS, that central fat deposition, the hyperinsulinemia is a growth factor that proliferates the endometrium and puts it at risk. So the Mirena IUCD is a godsend. So it's a fantastic thing. So that's the way to view it. I don't view PCOS as a significant problem. This is something, we all have something. This is something that's been managed through life, and we just need to have the appropriate treatment according to various epochs. That's the way I'm viewing it.
Absolutely. So there's one question which has come up, which is a concern, wherein you have a patient who's likely to go into preterm labor, and he does have gestational diabetes, and you want to give the steroids, antenatal steroids, for the sake of the baby's lung function.
Sure.
So can you safely give it? Would it cause problems to her sugar control? Is the question which has come up.
Well, absolutely fantastic question. So yes, it does. As we all know, it's extraordinary what the betamethasone does to the blood sugars. It sends it to skyrocket. So absolutely, I think obviously somebody on insulin, requiring insulin, you've got to be very vigilant, and that's something that we perhaps indiscriminately do without thinking of the consequences. So sure, a short-term thing is not going to cause a major issue for the long-term health, but certainly if you deliver the baby just shortly afterwards, it's probably going to be hypoglycemic. And we've already seen from the data I presented about the incidence of neonatal hypoglycemia. Fantastic question. That's something we have to be vigilant for. Great question. Yeah.
But it would be still more advisable to give the steroids rather than not giving them in such
Absolutely.
That's the message which should go across, right?
Oh, absolutely, 100%. Just watch the blood sugars, but you must give it. There's very good evidence about it protecting the long-term health. Absolutely.
The other question is that can we use the HbA1c, glycosylated hemoglobin, test for sugar in pregnant PCOS?
Yeah, that's a very good way of monitoring, and it's certainly for many patients it's more convenient than having to sort of go starved waiting for the blood test center to open. So that's a very good marker of that, and many obstetric physicians and obstetricians who deal with pregnancy diabetes use that as a very good monitor of longer term blood sugar control rather than just instantaneous blood control. This is a marker of about over a month. So it's a fantastic way of monitoring it. So absolutely, very good question.
So that these are the practical questions which people would like to ask and see what experts like you do in different parts of the world. And there's a very nice comment we have got from one of our very highly academic professors from Gujarat, who says he's enjoying this entire program. His stand on your stand on metformin is very sensible, and the data used backup is very good in quality. And your stand on inositols is revealing, and a clear stand on not using it as the data is still not convincing. It is very reassuring for people like me.
Oh, great. Thank you very much. I thank the doctor very much. Thank you.
So that's one of the remarks which has come in. So there are people watching all across, and I'm happy to see that we have, highly academic people also watching this program. There was one more question I had is that we say at some time that PCOS is a condition with chronic inflammation, or there could be signs, some tests which would recommend that there is some inflammation going on there, like you find the fibrinogen levels high, but in pregnancy it would be difficult to assess. So in such a situation, do you do anything for these patients? Do you give anything to the chronic inflammation part of it?
I think that's a fantastic question. I don't think we have any evidence to do that. But so the last reference I had from Stefano Palumbo and Bart Fauser in the review in Human Reduction Update, I think it was, and that's what they said. Pregnancy for women with PCOS is a state of inflammation. And these subtle markers that we perhaps don't focus on very much, like a higher white cell count, CRP being up, ferritin being, these are markers of subtle markers of inflammation that we tend not to really focus on. But great question, is there any treatment for this? I don't think we have any evidence that there is. I mean, that's a great study for somebody. Does metformin affect this? And randomize the patients. Does this reduce these? You could look at their inflammatory cytokines. Women with and without taking metformin, fantastic. But there's nothing that I routinely do, and there's no intervention that I would recommend. it's really just, we're just at the start of this. I think some work on limiting, that study I saw published in Lancet was underpowered, but it seemed to halve the rate of preterm birth. I mean, that's a fantastic outcome. If that was replicated in all over the world, and particularly in areas where there's low resources for resuscitating this baby, that could be a fantastic outcome. So I think there is certainly more work to be done on this, and it's a fascinating time that we're in.
Right. Okay, when you see a pregnant PCOS patient walking in, or even prior to a pregnancy, can you predict, just looking at her, as to what kind of complications? In short, I'm trying to say, will the phenotype help you to determine
absolutely. So basically, it depends if you've seen her beforehand. As Dr. Helena Teed's data sort of was suggesting, that often they can have poor appetite regulation, poor dietary habits. So these are probably the significantly overweight patients, and their pregnancy risks are much greater. But the slimmer patients without that abnormal eating behavior, the hyperandrogenic women are the ones at greater risk. And that's difficult because women go to great lengths to mask it, to have treatment to sort of minimize this distressing symptom of hyperandrogenism, which understandably they want to hide. So often we have to ask the question, because the data, I mean, it was amazingly consistent to all the different studies all over that I presented. They're the ones that are at greater risk. We do know that hyperandrogenism drives hyperinsulinemia, and we're not great at actually detecting hyperinsulinemia. There's many ways of doing it, and all things in medicine, if there's many ways of doing it, it means probably not a great one that we have. But we know that hyperinsulinemia is driven by high testosterone, and so that's probably what's underlying it. So if you see them preconception, try to get them as healthy as possible before you let them get pregnant. Yeah.
Mm-hmm. And do you see, I mean, I'm diverging a little bit from the pregnancy part, since we are talking about hyperandrogenemia. Do you tend to see, young girls, say, who have reached puberty a little early in life, and having a little bit of hirsutism starting up, or even the secondary sex characters developing much early? Do you tend to feel that those kids are the ones who will end up with PCOS?
Absolutely. And some fantastic work by Lourdes Ibanez in Madrid, who has a cohort of children with hyperandrogenism and early signs of puberty. She showed this extraordinary data. I mean, it wasn't huge numbers, but early intervention with metformin for girls with early signs of risk of premature puberty. They randomized the ones that took it. They had a puberty later, and actually they ended up being taller. Fascinating. So hyperinsulinemia drives the early pubertal growth spurt, and therefore almost certainly programs the PCOS phenotype. So it's a crucial stage of life, as you're aware. So yeah, absolutely, these girls are at risk, and so certainly girls with hyperandrogenic symptoms in adolescence, I frequently use the metformin, usually in conjunction with the pill. So I think the synergy between them is great, but there's some great work to be done about, can you alter the life trajectory of these girls? It'd be marvelous if you could.
Absolutely. And actually, based on that, we are having a very great course from the International School of Gynae Endocrinology, and we are focusing on puberty and adolescence in PCOS. Right. We're doing a program in November where we talk about brain and phenotype and stuff like that, which is early puberty. I think that will bring up a lot of new research which is happening.
Absolutely. It's fantastic. Yeah, no, absolutely, because you could affect their girls' life trajectory of health. I mean, that is fantastic. Yeah, that's great.
So there's another question which has come up, is where one of our viewers has asked that if a patient is on metformin therapy, in her first trimester, when do you need to stop it before you do a glucose tolerance test?
Yeah. So basically, I generally, I mean, whether this is old data, but we believe there's like 2 waves of placentation, which are ending about the end of the first trimester, about 12 weeks. So I basically say wean off at about 12 weeks. Don't stop it, wean off it. Interesting, my nurses tell me the patients, as soon as they stop it suddenly, they feel really, really sick. It's the same as when they started it weeks ago. So they gradually wean themselves off it. And then once they're off it, a couple of weeks later, then they can do their glucose tolerance test, because it doesn't, we take it to 2 and 3 times a day, so it's got a short half-life, so you can do your glucose tolerance test 1 to 2 weeks later. That's
so if a postpartum woman is on metformin, what do you do about her breastfeeding?
Postpartum on metformin, there's a great question. Well, I mean, that's a great question. I don't really think, do we have them on post? So basically, on metformin, because they've got impaired glucose tolerance in pregnancy. So it's not severe enough that they need insulin. So therefore, almost certainly when they're delivered, they need to stop. So it's rare that I've got a postpartum patient on metformin. And so, we do, I am a bit concerned about this data, which suggests that children born have bigger heads, that PregMet study, and that children who've been followed up for 7 years of age are bigger than those who are taking insulin. So I am cautious about exposing later in pregnancy metformin, and therefore I'm also very cautious about a woman breastfeeding taking metformin. So I really am not so sure about that's the right thing to be doing. I think we haven't enough data yet.
Right. So as of today, you would switch your patient off metformin if she's on metformin after the first trimester, number 1. Yep. If she's continuing metformin for gestational diabetes in case in the later part of pregnancy, then you would stop it post-delivery and you would not let her continue when she's breastfeeding. Is that right?
Yeah.
Perfect. Now there's one last question which has come in from one of our viewers who says, this is slightly away from today's discussion. I have a patient who's now 19 years old, known case of PCOS since last few years, irregular periods which become regular only with hormones. She's quite fed up with taking so much of medication, and she's following a low-carb diet, she's exercising. Is there any other long-term solution to this? She has also tried metformin, even though her BMI is normal. Probably she's insulin resistant, I don't know, she's not mentioned it here.
Oh, right. So her main symptom is what though, sorry?
Irregular periods.
Okay.
For which she has to take something. Okay. And she's not mentioned here whether the girl the BMI is normal.
Yeah. So she's exercising regularly. She's got a good diet, and she's got irregular periods. So firstly, you've got to say is it a nuisance? Is that a problem for her? So many a patient is just happy with all aspects of medicine. Just be reassured. Yeah. I know it's unusual, but that's not a problem. You're not going to incur any problem. Go along and see Dr. Shah when you're ready to start family. He'll give you something, and you'll be fine because you're a healthy woman. You just got slightly irregular periods.
Yeah.
I mean, it may be she's got a degree of hypogonadism. Maybe she's exercising more than you think. And actually, she's got a bit of LH deficiency, and that's why her periods are irregular.
Yeah.
So
it's possible that she's getting delayed periods, and then she's bleeding very heavily, and she's getting anemic. Then probably you would have to support her and bring on a withdrawal a little earlier, rather than letting her wait for 3 months before she gets a period.
Oh no. I completely don't show. With evidence would suggest that if you let prolonged time between periods is actually not a good thing for endometrial protection, unless the woman's got hypothalamic amenorrhea, and that's a different story. But so yes, so a sensible thing to do. She may want to do it. She's a young girl, but the pill is obviously to give her that menstrual reliability. So I think the first thing is to say it's a little bit unusual you've got, but there's nothing serious. There's a problem. You do not have to worry. She is doing fantastically well. You can say you're taking responsibility for your health, you're eating sensibly, you're exercising regularly. Those are habits which you must keep for life. Trying to tell a woman of 33 to lose all the weight, change her diet, start regular exercise, we know it's too difficult. The young girls who have that habit, they're to be commended and it's to be encouraged.
Absolutely. I think that's what we really need to tell them. They need to keep their weight under control and exercise to raise their metabolic rate, and I think they do pretty well as they go along.
Yeah,
is there anything you would like to ask us, Roger?
Oh, any questions? Well, no, there isn't. I mean, I've had some great insight into what goes on, and you've come up with some great ideas for research. I mean, it's fantastic, and I'm sure your population is substantially larger than mine to actually look at. But no, it's. I mean, I've really enjoyed this dialogue. I know you've come up with some great questions, because obviously I thought about what we were going, and they didn't go away. I thought it's been really fascinating insights, and I hope I've been able to summarize the literature.
No, I think it's been fantastic, talking with you, Professor Roger, and I look forward to meeting you somewhere in this world, hopefully, and. All the best to you, and
thank you very much. Thank you for inviting me.
Yeah, and I would like to acknowledge all the next slide here. I would like to acknowledge all the people who have supported us in this program, Professor Roger, Professor all the people who have supported it, the pharma companies, the USV who has been helping us with this program, our online delegates, and Monash University, which is our collaborator, and have been very happy to allow us to use the international guidelines as the background against which this program is being held. We will have the next program with Professor Unclear, which is on the 12th of August, and he will be speaking on hyperandrogenism. So that would be great, Roger. I think you should log on to this program for us also. And so this will be on the 12th of August, and this will be again at the same time as we are having this program today, between 2 p.m. to 3:30 p.m. Indian Standard Time. And this is what will be the 10th live session. I also want to announce this program which we are doing, which is a certified course by the International Society of Gynecology, and the focus is going to be puberty and adolescence. This is on the 9th and 10th of November, and our speakers are Andrea Ganazani, Alessandro Ganazani, Sarah Bourgeois, and Charles Sultan. So we have the 4 speakers coming in, and we look forward to all of you registering for this very, very interesting course. And thank you so much for being with us today. And bye-bye, Roger. It was nice meeting you.
Thank you very much for inviting me. Take care. Cheers. Thank you, Reg. Bye-bye.
Bye.
Bye-bye.